Today we're going to be talking about the sodium glucose 2 transporter inhibitors, or SGLT2s. You might be asking yourself, what are the SGLT2s and how do they work? When might I reach for them? And how do I educate my patient about them? What are our ADA recommendations around SGLT2 inhibitors? That's what we're going to talk about today. To better understand the medicine and the guidelines, we'll dive into a case, a 46-year-old presenting for a one-year follow-up new onset diabetes. He's coming in today 1 year after diagnosis. His A1C is 8.4, and at this point, he's only on metformin. When he presented 12 months ago, his A1C was 9.6. At that point, he was started on metformin. After 6 months, he completed medical nutrition therapy with a local dietitian. And in his last office visit 6 months ago, that's when we completed the microalbumin to creatinine ratio, which came back at 60, with the upper limit of normal being 30. So today he's back in his A1C again, 8.4, microalbumin was rechecked, and the ACR, or albumin to creatinine ratio, is 55, and his BMI is 26. The ADA is recommending SGLT2 inhibitors and/or GLP-1 receptor agonists for patients with established ASCVD or if they have high risk, as well as family history or if they have CKD. And for patients that have CKD, SGLT2 inhibitors are strongly recommended to slow the progression of their CKD. Since we're talking about kidney disease, I can't help but mention the new CKD guidelines from KDIGO, which actually just came out this year. I'll be publishing a video about that later, but they're also pushing for SGLT2 inhibitors as first line once the patient with diabetes has established diabetic kidney disease. When we start SGLT2 inhibitors with our patients, it's really important to counsel about the increased urination that they're going to get, since they work a little bit like a diuretic. This means that they have to pay really close attention to hygiene. Basically, SGLT2 inhibitors are making us pee out more glucose. So I tell patients that if they're not cleaning well, they have an increased risk for yeast infections and other fungal infections. You'll hear a lot about SGLT2 inhibitors and euglycemic DKA. There have been reports, and so in my personal practice, I'm very cautious depending on the A1C, but it's really tricky and there's no formal guidance. Simply put, the risk of DKA goes up as A1C goes up, and there was an interesting study recently comparing the risk of DKA with or without an SGLT2 inhibitor, and as the A1C increases, the risk goes up regardless of whether you're taking an SGLT2 inhibitor or not, but the risk is higher if you're on an SGLT2 inhibitor. I'll link to that in the show notes. So I've been prescribing SGLT2 inhibitors for several years, and there's no formal guidance of an upper limit of a cutoff to not start an A1C. Because you're so hyperglycemic, it can be really uncomfortable because you get that osmotic diuresis from such high blood sugar when you start the medicine. But at the same time, if the benefits outweighs the risk, then it's really important to start this medicine because it is life-saving. So how do they work? Well, they increase the glucose concentration in the urine, inhibiting the sodium glucose 2 transporter. They're thought to decrease glomerular pressure, and they have a lot of other cardiac and renal protective benefits, but we're still investigating how those work. So SGLT2 inhibitors have been a game changer in the management of type 2 diabetes. They're a great second-line agent after metformin. Really important to educate our patients about the side effects. The medicines can be a little uncomfortable to tolerate if you don't talk to your patient, and also always keep euglycemic DKA in mind. It's not a reason not to start the medicine because these are such life-changing, incredible medicines, but do be aware of it.